go, 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 go. That's the birthday. That's the birthday.
Blame it on the goose, got you feeling loose. Blame it on the Henny, got you feeling smelly. Blame it on the alcohol. Blame it on the What's up, Z-Pack? It's your boy, Z-Dog MD, and we are coming live and direct out of Z Studios. Today we're going to do a new thing called Tribe Teach. We are going to teach about a topic. In this case, it's going to be alcohol withdrawal. Why? Because y'all F it up every day. I've seen residents and full-fledged attendings screw up the management of alcohol withdrawal, and it is a legit problem in our hospitalized patients and our unhospitalized patients, and soon in Tom Heinemer, but he switched to weed because...
That's why you gotta smoke that ganj, people. You know what I'm saying?
Hey, yo, teach! That's why they call him Tom Heinemer, you know what I'm saying?
Oh, snap!
You see what I did?
Yo, teach me up, dog.
Yo, I was gonna teach, but then I got high.
Why, dog?
And then I was gonna teach, and then, okay, anyway, so check it out. I wanted a little bit of housekeeping first. So on Patreon, if you go to patreon.com/ZDogMD, you can actually support this podcast and show and live enterprise at any level. $1 an episode, $1 a week, $5 a week, $2,000 a week. And one of the people who supported us at a good level gets a reward, and that is a shout out of her choice on the show. And do you know who that person is? It is a lovely emergency nurse in Texas, which is deluged currently, and all our thoughts and prayers are, I'm agnostic, all our prayers and meditations are going out to Texas. And everybody out there, because they are, it's amazing. Didn't more people saved fellow Texans on jet skis than the Texas government did?
That's what I've heard is, I don't know if that's apocryphal, but it sounds awesome.
It sounds amazing.
Yeah.
And
they said people are just going out on jet skis, boats, whatever they got, and just like making it happen, inviting people into their homes. It's just like, you know, Texas, y'all, what's up? Shooting shotguns at the hurricane, trying to make it go back to his home country, because we don't want your kind here, Javier. You know what I'm saying?
America.
Sweet baby Allah. Don't mess with Texas, because even a hurricane cannot harm the spirit of Texas. But we are thinking about everybody in all the hospitals there that are affected. And Sunny Bogdan, emergency nurse in Texas, had her birthday yesterday. Happy birthday to Sunny! Thanks for giving us money. So, Sunny, we love you. You're Hella Health 3.0. We got to meet when Tom and I were in Houston speaking at the National Athletic Trainers Association. So we love Sunny. If you want a shout out on the show, or someone you love, you want them to get a shout out, help us out on Patreon, because it helps support our show. It buys Logan more guns. It buys Tom silly weed hats that we also get for free from people who send them to us. And speaking of the National Athletic Trainers Association, we did that conference in Houston a couple months back, right, Tommy?
Yep.
And let's go to the inset cam. I
Back when
just
Houston was
got
not full of water.
an adorable little card from somebody who was at the conference, and I want to read it to you. It says, Dr. Z, heard you at NATA. We love what you're doing. It was so nice to hear someone appreciate our athletic trainers. My daughter is in her third year as an athletic trainer in high school in northern Texas. Texas represent again. I was her guest, and you just made so much sense. I'm actually going to get my certification as a health coach after hearing you and having a heart for helping people. Please accept this gift and spreading this awesomeness. Jennifer Regan, R-E-G-E-N. Check this out. She made, we're gonna have to go to the TAD cam for this.
Boom.
She made a healthcare 3.0 shirt. Look at that.
It's gangster.
Amazing. And look at the back. Luckily, I'm red-green colorblind, so I can't read it all. It says the next generation of healthcare. So that is the kind of dopeness that the Z-Pack represents. And it's good that we get to travel around and talk about Health 3.0 and do these live performances, because I think they do actually affect change, because she's going to become a health coach now. And I have a dope shirt. Thanks, Sunny Bogdan. And let's start teaching. What do you think, Tom Heinemer?
Hit me up, teach. I need to know what I need to do next time I get the shakes, dog.
Son, if anybody's got the DTs, it's Tommy T. You know what I'm saying? All right, here's the deal, guys. Let's be serious for a second. And I wish we could have offered CME or CEU for this, but it's a pain in the ass and I don't want to do it, so screw you guys who are asking for it.
Yeah, plus now we can say bad words like fuck and
Whoa.
and all kinds of cool
Yeah.
stuff.
The other thing you can't do What'd you say, Logan?
Communism.
That's
the
the
communism.
That's the dirtiest word
That's
of all.
That's the dirtiest word of all.
The other thing you can't do in a CME broadcast, I bet y'all didn't know this, is drink LaCroix. Wave an American flag because America is a branded entity.
Oh,
It's
yeah.
America TM.
Don't you bring that French shit on the show, Zay.
America's the biggest corporation in the world, y'all. Killing it.
AmeriCorp.
How's business? Booming.
TM. All right, so I want to talk about alcohol withdrawal, and there's a reason. I am a hospitalist, and I see a shite ton of alcohol withdrawal. And throughout my history in medicine, I have seen it mismanaged. And the thing about alcohol withdrawal that you have to understand is, first of all, it's a massive problem. People underestimate this. So we've done episodes of the show about alcohol use disorder and Tom being a drunk and all kinds of things like that, right?
Alcohol use disorder is just alcoholism. They renamed it because they want to be fancy.
And you know what? We are so fancy in the healthcare game. We're so fancy. We called it alcohol use disorder. And the thing about alcohol use disorder is it's pretty prevalent in the general population. But listen to this: 40%, according to some estimates, of the hospitalized population actually suffers from an alcohol use disorder. So some variant of alcoholism, to use the lay term. Now, this is a big problem. Why? Because while opioid withdrawal, you stop opioids, feels like you want to die, you rarely do. Alcohol withdrawal can kill you, like dead as a doornail, and in a horribly unpleasant way. So when you take a patient into the hospital and they don't drink alcohol, and they drink alcohol a lot and regularly normally, they can go into a kind of withdrawal, and you will see some very interesting patterns, including death. If you don't manage it aggressively quickly, it's almost like sepsis. If you get too behind, you can drop the ball and the patient can die. And so what we want to do today is talk about how you guys are going to actually save lives. And I'm looking at you, docs and nurses and respiratory therapists and people on the front line touching patients, because you are responsible for saving these lives. If 40% of people in the hospital may have some variant of alcohol use disorder, or I find that a little bit high, you can do a lot of good here. All right. Why, first of all, do you withdraw from alcohol? Like, why is it a problem to stop drinking if you drink a lot? Well, Tom, do you even know how alcohol works? Does anyone know how it works?
It does something to your liver,
Makes you
and
feel
then
good.
you can't process stuff in your liver like normal, so you feel awesome.
And ladies look prettier.
You know, people strangely accuse me of being a bro scientist. And I'm like, why? I'm a UCSF trained, Stanford trained hospitalist in the academic circles, and have done this and that. And I think it's because of you, Tom Heineber.
Yes.
I think because you are my bro. And I'm going to wear that like a badge of honor.
I love you, bro.
I love you too, bro. But if you ever withdraw on me, I will literally euthanize you.
Don't you withdraw on me.
Don't you withdraw on me, Tom Heineber. So here's the deal. The way that it's felt, alcohol exerts some effect, is on the GABA receptor system in the brain. So GABA is gamma-aminobutyric acid. Who cares, right? It's yo GABA GABA. It's an inhibitory neurotransmitter. What that means is it's brain cells telling other brain cells to shut the fuck up. So stop making excitations, stop doing stuff, calm the hell down. That's what alcohol does, which explains a lot of things, because if it's inhibiting inhibitory centers of the brain, you get disinhibited and you get hella beer goggles and you wake up having to gnaw your arm off, right?
That's when you do cool stuff and have fun times.
Like break your finger playing a video golf game at the bar.
This is the whitest injury you can have, people. I got this playing virtual golf. Okay? I'm not proud.
You know what? People talk about white privilege. This is the flip side of that. It's white stupidity. Right? So in any event, you see why we don't want CME? Because it comes with a lot of, let's just say, imperial entanglements. So in the GABA system, you're inhibiting neurons, and alcohol does that too. So it affects these systems. When you pull the alcohol away, it turns out GABA receptors that have been used to high levels of alcohol start to kind of go, we don't need that many of us, and let's kind of downregulate us, and let's do different things to how we process ion channels and things like that and other mumbo jumbo, that it becomes a new normal, that you're used to certain amounts of alcohol through the dependency on the alcohol, the sedative effect. When you take it away, suddenly you don't have all this inhibition, and the excitatory elements start to fire up. Because the other thing alcohol does is it actually inhibits some excitatory neuronal pathways as well. So by stopping excitement and increasing inhibition, when you take it away, the opposite happens, and people get. So that's why you can see things like agitation, insomnia, vomiting, tremulousness.
Oh, dude, you see all kinds of things on alcohol, dude. It's crazy on alcohol withdrawal.
Wow.
Those are your
you went
GABA
full
receptors.
GABA. You know what I love about you guys? You really are the perfect bro scientist. Like, I'll say something like, yo, it's GABA, and it's like, next thing you know, it's yo, GABA, GABA. It's incredible. Look at that. Oh my gosh. By the way, that show, whoo, hello. So here's the deal, though. The kind of symptoms that you can have, and it's interesting. So in the 50s, Tom, they did a study. They took a bunch of alcohol-naive patients, so people who didn't drink. So basically Logan. And they gave them a shit ton of alcohol for a long period of time, and then they gave another group like just intermittent alcohol, like you.
Yeah.
And what they found is it was the group that had the regular alcohol that were more likely to have withdrawal.
Right.
You could do those kind of trials in the 50s. It's like, let's induce alcohol withdrawal in a bunch of young kids who've never drank. It's amazing. It's like a little scientific hazing.
Well, because when you're doing it intermediately, you're having withdrawal. It's just very minor, right? Isn't a hangover just very minor
It's partially
withdrawal?
a hangover. It's partial kind of mini withdrawal. But see, your receptors in your brain never have a chance to really adapt to high levels of alcohol, so they don't reach that new step point. But that does not to say that you can't withdraw doing binge drinking. So some people will have that. But really, it's a long-term drinker. It's that guy, the homeless guy that you see that's just like drinking every single day, or the high-level executive who no one knows, but he's having 3 martini lunches and 2 martini breakfasts and 10 martini dinners.
I could never do that. Could you ever do the wake up and have a Bloody Mary or whatever? I can't do that. It sucks.
It makes me want to puke.
Yeah.
Yeah. It's not for me.
I need to just take my hangover. Like, I had my fun. Now I take my hangover
It's
right
time
now.
to take your pills.
Yeah,
Yeah,
exactly.
yeah. Well, so speaking of all that, so when you take the alcohol away, and this is the trick, a chronic drinker often doesn't choose just to stop drinking. A lot of times it can be something like an illness or a problem or some other issue that triggers them to stop drinking. So maybe they have pancreatitis, maybe they have an infection, maybe they have a heart problem, maybe they have a kidney problem, maybe they have liver disease that's flaring up and they're losing their appetite, their ability to drink, and then they're coming into the hospital being weird, and you're like, well, it's alcohol withdrawal. Well, it could be that. It could also be the underlying disease, so you have to be really careful. So, Logan, pull up the slide that I have from Up to Date, which is my favorite.
That one, Z?
Yeah, that one. That one. Yeah. Well, can you give me citations on that?
Yeah, that was from Mr. Gaba.
Mr. Gaba et al. That was a y.gaba et al.
Yo.gaba.
So this is a good, simple table for the kind of symptoms and signs that you will get in different flavors of withdrawal from alcohol. And remember, they all kind of make sense because they have to do with taking away the sedative component, right? So in the top there, sort of this mild withdrawal stuff, you'll get shakiness, that's tremulousness, mild anxiety, headache, sweating, that's diaphoresis, right? Palpitations is the heart racing. Anorexia, meaning you don't want to eat, GI upset, we all know what that is. And generally, your mental state is normal. So if you ask somebody where they are when they were born, who the president is, they will tell you all the horrible truths, right?
Trump!
Yeah. And so that's, and that kind of withdrawal can happen as early as 6 hours after your last drink, if you're a heavy drinker, or up to 36 hours. Now, that's mild alcohol withdrawal. We should learn to recognize it, because in hospitalized patients, you can miss it. You can think, well, it's somebody who's anxious, or there's another medical problem going on, or some other reason that this is happening, or we just blow it off as somebody who's fidgety and kind of goofy. And here's the thing, nurses are the ones who are going to catch this, because they're with the patient all the time. You know, the residents and the docs are coming in, they're doing the U-turn at the foot of the bed, and they're walking out, and they're missing these subtle signs of alcohol withdrawal. That's why this is so important for nurses. In these situations, nurses can 100% save lives and affect outcomes. All right, so go back to the slide, Logan. Now, a little bit further down the line is seizures. Now, seizures can happen 6 to 48 hours afterwards. Now, remember, seizures can happen because you're pulling away all this inhibition. Now you have all this unopposed excitement in the brain, and that excitement can lead to electrical storms that cause seizures. These are usually kind of single seizures, and people think, oh, it's benign, it's not a big deal. The problem is the more you let those go, the more you can kindle future seizures from withdrawal and go into and have other problems. Status epilepticus, which is continuous uncontrolled seizure, is fairly rare in alcohol withdrawal. And remember, in between the seizures, oftentimes the patient might seem completely normal. So have you ever had any friends who've had seizures when they've stopped drinking?
I have had friends who joke about getting the DTs and also will do things like put an Alka-Seltzer in a vodka and keep drinking in the morning. And then you'd be like, remember when you had the DTs? And they'll be like, no, I didn't have that, dude. I'm not alcoholic, bro. What are you talking? Not you, man. Don't do this to me, Tom.
I learned it from watching you, Tom.
Learned it from watching you,
No,
Tom.
I mean, but all joking aside, that's a problem. That is a problem. So we have minor withdrawal, we have seizures. Now, this is where it gets interesting because alcoholic hallucinosis, many people misunderstand and misdiagnose this. This is a visual or a hearing hallucination or a tactile. Tactile means you feel stuff. And the classic example is something called formication. Don't laugh at me, it's not fornication.
Formication.
Formication, forma from the Latin root for ant. And it's the feeling that ants are crawling on you.
Ugh, gross.
Yeah, and this is a not uncommon thing. But the interesting thing is people are 100% aware and alert and able to tell you, oh my God, I'm hallucinating, like I'm seeing a rat running over there, or I see insects buzzing, I hear some weird stuff, or I feel like ants are on me. And they'll look at you like, what's going on, doc? Like, Trump is still the president, it's still 2017, and my name is this. So they're alert and oriented, they can spell world backwards, they can do all this other stuff, but they're seeing shit.
Yeah.
And that's alcoholic hallucinosis.
What's interesting is that says it's alcohol hallucinosis, but I always thought that was delirium tremens. I thought that was the delirium, and then, like the beer delirium tremens has a pink elephant on the bottle.
Yep.
Right? It's like a really high quality beer. But it's actually
I've had it, it's
amazing.
really
Yeah,
quite
amazing.
good. It's
But
high in alcohol.
so I always thought that was the auditory, like visual hallucination part.
So let's get to that. So, and again, these have different time courses of when the last drink was to when you see this. Now, alcoholic hallucinosis, seizures, minor withdrawal. The key thing here, Tom, is that you have a pretty good mental state. You can hold a conversation, you're in your right mind, you're not showing elements of delirium. Now, withdrawal delirium, also called delirium tremens, is the extreme sort of worst stage of alcohol withdrawal. And this is a stage that can often, in the old days, was up to 40% of patients died if they got this. Because we didn't know how to treat it, we didn't have the supportive care, which, by the way, I want to say one thing to the motherfuckers who are constantly like, you know what, medicine doesn't do anything, we should go back to natural shit, my chiropractor can help me. Yeah, try alcohol withdrawal. Right. This is one of those cases where you can save people's life with Western medicine and science and ventilatory support and the whole thing that we do.
What do you have to do before the treatments we have nowadays? You just had to taper them?
Well, I'll tell you what we used to do at the VA, and we even knew better. We would give them beer.
Yeah.
So if someone came in alcohol withdrawal, we would give them beer. Now that's frowned upon because for several reasons. Alcohol, actual ethanol in sick patients, we don't know the kinetics of it. It's unpredictable. Right. It causes other harm. And so the thought is there are better ways to treat it, but we used to give them, and in VA, government-issued beer, you could order it from the pharmacy. It was a white can. Logan would love this. A white can. This is what happens when communism wins, Logan. You get your beer is a white can that says beer on it in black letters. That's literally what it was. Tell me, Z-Pack, has anybody ever ordered beer at the VA? Because that's government-issued beer. Tap the Rockies, indeed. So delirium tremens or withdrawal delirium. This is, let's pull up that slide again, Logan.
Boom!
That's the bottom one. So delirium, let me describe what that is. Delirium is, the simplest way to describe it is you have a inability to pay attention to anything, and your level of attention goes up and down. Exactly. Gabba, gabba, gabba. That's delirium. Logan is chronically delirious. You don't, you don't quite know where you are. You can't sometimes know who you are. You don't know the year, and this can fluctuate. In the setting of that, your level of consciousness changes. You're awake, you're asleep, you're drowsy, you're agitated, all over the place, right? And this is delirium. Now, agitation is, again, this activation. You're bouncing off the walls. Tachycardia is a fast heart rate, and this can get really fast, like above 120 and higher. And it can lead to other arrhythmias like ventricular tachycardia, torsades, these kind of deadly, potentially deadly heart rhythm problems. Hypertension, so high blood pressure, fever, and diaphoresis is sweating. Now, why? Well, it turns out that alcohol has these central sort of calming effects, but it also has some peripheral calming effects as well. When you take the alcohol away, everything goes to shit. And the people who go into delirium tremens tend to be the heaviest drinkers. They tend to be older. They tend to have had previous episodes of withdrawal with symptoms. And so they can often have coexisting liver disease and other problems that make them higher risk at many levels. And that may explain the higher mortality. Nowadays, the rate of death from delirium tremens is down to about 5%, which is still really high.
That's pretty good, though.
It's better, and the reason is we learned how to treat this stuff, and we're better at it. But we still suck, and I still see people screw up all the time. First of all, by not recognizing what stage of delirium you're in. Second of all, by under-treating it. Third of all, by missing an underlying cause, right? And those are the main things. And I'll tell you, I have stories, and when we talk about treatment here in a second, I'll tell you some of these stories of like literally VA patients up all night and me giving them Valium and Valium and Valium and Valium and Valium and them literally coming out swinging, and me with the nurse just going, what the hell are we going to do? and here's the thing. If you get behind on treating it, it becomes this desperate catch-up, and they get to the delirium tremens stage, you're screwed. Now here's the thing. The thing about delirium tremens is that it's almost unheard of to not have previous signs of the other versions of alcohol withdrawal. So you might have the shakes and the hallucinosis, you might have a seizure, you might have a little bit of fast heart rate, you might have sweatiness. Insomnia is a common early sign of alcohol withdrawal. So you should be warned that the DTs, as Tom calls them, could be coming. Now the exception is, imagine this situation. Tom is an alcoholic. He is a homeless guy. He's found down in his own stool.
Hell yeah.
They don't know what's going on. Turns out he has a burst appendix. He drinks every day on the regular.
On the reg. Yeah,
He's,
that's
because
my life,
why not?
He's woke.
He's woke. He's woke AF, people. So Tom ends up getting rushed to the OR, where he has a perforated appendix. They fix this stuff. They sew him back up. They put him in the ICU. He's on a ventilator. Wakes up. He has not had a chance to objectively show signs of alcohol withdrawal. 3 days go by. He's like sitting there chilling, and he's apeshit crazy. He's absolutely delirious. He's pulling out all the lines. His blood pressure is 180. His pulse is 150. And his magnesium is dropping. His potassium is dropping, because this is one of the things you see in florid delirium tremens is all your electrolytes go wacky. Partially renal problems, partially liver problems, partially fluid balance problems because they're not eating, they're not drinking, etc. There are vitamin deficiencies in chronic alcoholics, thiamine, etc., etc., etc. So all this can happen and you will have no warning.
Also, I'm hella unpleasant, and I say shit like, go get me a sandwich, bitch, or I'm gonna shit on the floor. And
True
it's not
story,
and it's not a vacant threat. I will do it.
True
I will
story.
shit on the floor. Looking you right in the eyes.
His name's Mr. Bulldog.
It's rare that it's rare that you make me laugh like that, and the reason I laugh is that I've had patients exactly like that.
Yep. No,
They will
that's a real.
literally take a
That's,
shit on the floor.
that's a real story that
That-
my wife told me by a lovely homeless gentleman here in town.
Oh, I know you're talking.
Oh, Ashy Larry.
Ashy Larry.
Ashy Larry. So when Ashy Larry goes into withdrawal, first of all, let me make sure that I'm going to plug, because I took a couple of quick notes. I want to make sure I told you stuff. One of the things you have to know is that the symptoms of alcohol withdrawal can emerge, especially in chronic alcoholics, while you still have alcohol in your blood. So you can have a blood alcohol level of like 0.5 and still start having withdrawal, because relative to what your needs for alcohol are, they're not quite there. So remember that. Just because you have alcohol in your blood doesn't mean you can't have withdrawal.
Right.
All right, so that's one piece, and then the other. So let's get into. I think we should get into how to treat this, right? Because we can see now, how do we recognize it? You see the symptoms, you see the signs, you know that it could be fatal, and the way people die. By the way, how do you think people might die from delirium tremens? Because it seems like it's just like a bunch of weird symptoms. And are you gabba-gabbying me? God damn you, Logan Stewart.
They probably die because they get too woke. You know what I mean?
They say woke. And then the wokeness builds up, see?
No, we're not bro scientists. We're legit scientists. Yeah, you get hella woke and then
Let me see if I had to imagine. I don't know.
think about it.
Heart
from-
attack?
That's a great point. So cardiovascular death is one cause because you're putting a system under a lot of strain. So you can either have a heart attack, you can have an arrhythmia, meaning the heart beats funny and you die. So anything from atrial flutter, atrial fib, ventricular tachycardia, VFib, et cetera. And that can be made worse by electrolytes. So if you're not monitoring their blood electrolytes, if you're not giving them fluid with glucose and thiamine, a lot of times because they're often deficient in that. If you don't give glucose with thiamine, you can precipitate something called a Wernicke's crisis, which is no good. So you can die from that stuff. You can also die from aspiration, which is a fancy way of saying choking on your own vomit.
right.
Choking on your own vomit. Because you're not in your right state of mind, which means you're not protecting your airway, you're not controlling your secretions.
Tons of rock stars have gone out that way. You know, Jimi Hendrix,
Hendrix went out.
Bon Scott.
Yep.
The list goes on. And
Billy
on.
D. Williams.
Yeah.
Yeah.
No, he's still alive.
Damn it.
Actually. Hey, Jaylene says, I learned about the DTs from Leaving Las Vegas. I guess that's the only thing Nick Cage ever taught me. Have you seen Leaving Las Vegas? It's actually a really great movie about an alcoholic.
I haven't seen Leaving Las Vegas, but I've seen Nick Cage at my kid's school.
I've seen him drunk.
Yeah, now let's just
Really
say,
drunk.
if anybody's going to need some CWA protocol, which we're going to talk about in a second, it's going to be my boy,
Oh, yeah,
Nicky
your
Kid.
kid and his kid are in the same grade, right?
Yep. His kid, I won't say his name, but he named him after a Superman character.
Oh, yeah,
Yeah.
that's right.
Yeah, really, again, I'm going to not violate HIPAA. He's not my patient, but he's a celebrity. So all that being said, you can die from delirium tremens. So you want to look at electrolytes, you want to give fluid, you want to, nutrition is important. If people can take orals right away, you do that. Now, how do you actually treat alcohol withdrawal? We don't give beer anymore in the hospital, right? And here's something I also see. Someone has an alcohol withdrawal seizure and they give Dilantin, phenytoin. That's a typical anti-seizure drug you would give for seizures. Is it the right thing to do? Oh, hell no, Z-Pak. So there's been data that it doesn't help with alcohol withdrawal seizures. The way you treat alcohol withdrawal, the seizures, the tremulousness, the DTs, etc., is with benzodiazepines. That's the frontline agent. Benzodiazepines are things like Valium, Librium, Ativan, Versed. Those kind of agents that act in a similar way. They're GABA receptor or GABA. There it is. There's my boy GABA. GABA stimulants. So they're gonna suppress the activation of the brain.
Right.
And so what you're doing is you're taking a pharmacologic sort of version of methadone, basically, for opioid abusers. And the advantage is it's more predictable, so most of them are cleared in the liver, a couple are cleared in the kidney, like Ativan, so you can kind of dose them appropriately. You can give them IV in terms of Ativan and Valium, or you can give them orally in terms of Librium, which is much longer acting. And you can titrate them either in a standing way where you say, I'm just going to give him, I'm worried about this guy, I want to not let him go into withdrawal, or he's got some withdrawal, I'm just going to give him Librium 3 times a day. That's how they used to do it. And then they did this couple of studies in the 90s, and they found that, no, it's actually much better to titrate how you give these medicines to the patient's symptoms. And that's where it became a nursing nightmare. Because this is what happened. They came up with this thing called a CIWA assessment. It's the Clinical Institute's Withdrawal Assessment Scale for Alcohol, or CIWA-AR. And this is a hellishly complex series of questions that basically that the nurse basically has to assess, or the doctor has to, usually the nurse. And it's things like, are you feeling any headache? Do you have any anxiety? Are you feeling nauseous? Do you feel like you want to drink? You know, whatever they are. And there's like a bunch of questions. And I had the slide and I didn't want to inflict it on you. You can look it up. So based on the number score on the CIWA protocol, you can actually decide, do I treat or not, based on mild, moderate, or severe withdrawal symptoms. And that requires constant assessment, so almost every 1 hour when you're starting, which is very hard for nurses because they're understaffed already, and now they've got to ask this crazy alcoholic a shit ton of questions. And that's assuming he's in his right mind to answer.
That's right.
And if he's not, you can use something called the RAS, which is a different assessment tool. It's more based on objective measures that you can use in ICU patients or patients that are unable to cooperate with the CIWA. Of course, if they're unable to cooperate with CIWA, often they're in serious withdrawal. And,
Yeah.
So once you you kind of document, okay, this guy's actually got withdrawal, then you got to start giving the benzos. And this is how that's going to look. So let me make sure that we go very carefully here because I don't want to.
I found a picture of the Siwa.
Oh my gosh.
Yeah.
Blackfish.
I was like, why are you Googling SeaWorld right now? And he was like, SeaWorld. SeaWorld.
thing.
It's a funny joke.
Panda.
It doesn't
Panda,
make any sense.
Panda.
I'm
I got
funny.
dolphins in Atlanta. So typically, you can start with longer acting benzodiazepines, but you have to be careful. So things like Valium that are oral, 10 milligrams orally, and just repeat, every hour until the patient is calm and the CWA score drops. And you have to be careful because in people with liver disease, the metabolites can build up and you can actually really oversedate someone and it will all suddenly catch up with you and the patient's not breathing.
Hey, yo, Teach. Bro science moment. Aren't you just using drugs to, like, fight drugs, bro?
Yes, that's exactly what we're doing because we want people not to die.
But, bro, real quick, bro. Ativan's, like, totally addicted, bro. So, you just gonna get them all strung out on Ativan? Stop putting the SeaWorld thing.
So actually, it's funny, Tom, that you bring this up. So there are non-benzodiazepine pharmacologic approaches to treating alcohol withdrawal. They don't work. They might work in very mild withdrawal, and some mild withdrawal just resolves on its own, but you don't want to take that risk in the hospital, and these patients are already addicted to alcohol. It probably isn't a good idea to send them out on benzodiazepines. You detox them, get them through the withdrawal, make sure they're stable, and then get them into treatment. Of course, that never happens. They go back to the street and they continue to drink.
Right.
So that is a dispo plan. That is a discharge plan. It's always worked for me. It doesn't solve any problems, but that's Health 1.0 and 2.0 for you guys. When we get to 3, it's a different game. So the basic protocol is if they can take oral medications, you can hit them with Librium, which is chlordiazepoxide, and they're calling it 25 to 100 milligrams, repeat every hour until the CWA score is less than 8. And if you can do that in 3 doses, then that's great. Then you can give a little bit of Versed or Ativan IV just to get them calm because that's much shorter acting. It's cleared through the kidneys. It doesn't stack as much. It doesn't have active metabolites. That's why sometimes you'll see docs give Valium initially until they're a little bit calm. This is what I used to do. And then just bump them with Ativan, PRN as needed for a little bit of, for whatever symptoms they're having. And you treat it to symptoms. And slowly their need for that inhibition drops and then they're clear and you're good. Then you can talk about, obviously you're treating the underlying condition and you're taking care of what's their long-term sort of get them off alcohol plan, right? And that's a treatment issue. Now, if you can't do that, if they're not taking orals, then you got to hit them with IV. And you can do IV Ativan, which is again is short acting. I prefer Valium if their liver is okay, and even if it's not, sometimes I'll give a little Valium and that'll hang around and it'll knock them down a bit and their symptoms will calm down, they'll stop seeing things, they won't seize, there it is. Or they, and they'll have less tremor, they'll feel better, they'll be more alert. When that happens, if they get a little shaky or they're a little tachycardic or their blood pressure's up, you can bump them with a milligram here and there of Ativan. And as their need comes down, you just bump, 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 bump. You can consider they have a need for alcohol that's decreasing. If you don't meet it, they're having seizures and withdrawal and delirium. If you meet it, you're perfect. And if you overdo it, they're sedated. So you're trying to just bump around this decreasing line. That's how you manage that. And the whole time you're giving fluids, you're giving magnesium, you're giving potassium, you're replacing the electrolytes, you're checking the labs, and you're watching for underlying disease to make sure you're not missing something like a pancreatitis or a GI bleed or a sepsis or an infection. So if you do that and they do well, you won the game. If they don't do well, if you get behind, if you can't calm them down with this IV stuff, then you start escalating. If they go into florid delirium tremens, they're agitated, they're not protecting their airway, that's when you intubate the shit out of them. You put in a breathing tube and you sedate them with propofol. Propofol, milk of amnesia, as Doc Bader calls it, will knock you out and keep you generally quite good while you're intubated. Now that's a serious thing, and now you have all the potential complications that come with being on a ventilator, being in the ICU, infection, aspiration, clots, and then whatever the underlying condition is. So that's a serious thing. Along the way, you can give phenobarbital too. That's another thing that under supervision, you often need to be in the ICU. You can give phenobarb in addition to the benzodiazepines to try to see if you can knock the alcohol withdrawal down.
When you're saying you're titrating down according to symptoms, if you choose the wrong drug, could you end up stacking?
Exactly. So this is what happens. And you see, okay, here are the mistakes that I see. Intern comes on service, patient's in alcohol withdrawal. Nurse calls him in the middle of the night. This patient's jumping off the wall, saying he's seeing ants. His blood pressure is 160. Help, doctor. So the intern shows up and says, okay, I read that I should give Valium. Doesn't really think that the patient has cirrhosis, end-stage liver disease from chronic alcohol abuse. His liver doesn't work that good. Valium is cleared through the liver. So what happens is he gives 10, and he gives it IV because the patient's not swallowing real well. They can't trust him. He's throwing his meds all over the place. So he's like, I'll give it IV, which means there's no autoregulation. In other words, you can give it IV even if the patient is a little bit sedated or something's going on. So he tells the nurse, give 10. Okay, he gives 10. Patient's still jumping off the wall. Give another 10, 10 minutes later. I have given Valium every 10 minutes IV, 10 milligrams until a patient is calm. And you just sit and watch. You have to be there, which means not only do you trust and rely on your nurse, but you have to actually show up as a doc, right? And you have to sit there with the nurse. It's stressful. Like the scariest shit I've ever done was alcohol withdrawal at the VA when I was a resident. You're sitting there with this patient who's bouncing off the walls and their blood pressure's crazy and the nurse is looking at you like you're the doctor. Do some shit right now. Because, and here's the thing. The nurse is scared to give the Valium because she's seen people die from too much Valium.
Right.
And her shit's on the line too.
Yeah.
So
and you got to know as the doc which one is the correct drug to be giving so that you're not stacking it up inside the patient.
Exactly. So this is what happens. They give the Valium 10, then tells the nurse, give the Valium 10. At this point, the third dose of Valium, patient's still jumping off the wall. The nurse is like, doctor, could you consider that maybe the patient has too much Valium? No, he's still bouncing off the wall. Give him more Valium. Well, he's got florid liver failure. The next thing you know, he's quickly unconscious.
Yeah.
And he vomits, aspirates, chokes on it, gets pneumonia, is in the ICU, and dies.
Yep.
And so this, and sometimes that happens quickly, sometimes it stacks over time. And I've seen this happen. And the worst part is it's often combined with other things, like patient may be getting narcotics for something, something else is going on, right? He has a GI bleed, so he's what they call encephalopathic, meaning he has a delirium caused by liver disease, and it's very complicated. We'll talk about it another time. Yeah. So all those things, you can kill a patient easily. So this is what I do. I give them Valium. Okay, they're still wide awake. I might alternate it with a little Ativan, because Ativan is cleared through a different pathway. It doesn't have active metabolites. It's shorter acting. You can even give Versed, which is even more short than that. And that way you can kind of watch, and if that doesn't work, maybe give them another Valium. And it's a very hands-on process. And it depends on the nurse's assessment, on your assessment, and your understanding of the overall picture of the patient.
But if it's such a labor-intensive hands-on process, is the hospital the right place to be doing it?
There's no better place. Because you can't do you can do alcohol detox as an outpatient, but not this, not delirium tremens.
But do you need you need a sitter for them, or do you have to have the doc be there?
No, you probably need a sitter. The doc won't be there because docs are stretched thin. The nurse will be with her 5 other patients running around. The sitter will be in the room.
So who's the sitter?
Well, the sitter may be,
it
may be a
family member,
a CNA. It may be a family member, although that's not super smiled upon. It depends on the institution. So that's the trick. Everybody's understaffed, and you're trying to take care of a very high intensity thing. So sometimes you'll just have to bump them up to a higher level of care, a step-down unit, a ICU, because then you have better staffing, right? So, and remember, guys, like if you're a doc, and if you're an intern, there's going to come a point, and there are criteria for this, where you're going to go, you know what, this patient needs the ICU. This patient needs 1-to-1 or 2-to-1 nursing. They need monitoring. They need cardiac monitoring as well, because they're having tachycardia. They could have an arrhythmia. Their electrolytes are out of whack, all those things. And you're trying to give these benzos, and it's getting behind. And when that happens, it may be getting time to intubate the patient, hit him with propofol. There are other things you can do as well, right, we won't get into. But the main points I want you guys to realize is if you get too behind, you can you're spending the rest of the time catching up, and it can be fatal for the patient. If you overdo it because you haven't thought about liver disease and that kind of thing, you can cause death and harm. So generally, but the one thing I want to say is more often what I see are that people underdo it. So they're scared. They're like, I'm going to give, I don't know why I'm doing this voice, but I'm going to give like 1 milligram of Ativan because I don't want anyone to die. And the patient's jumping off the walls, and the nurse is calling and calling and calling, saying, Doc, the CWAS score is like 15 or whatever. this is not enough. Give them another one of Ativan. Well, Ativan is like, it's spitting at a guy who
Right.
drinks a fifth of vodka a day. It's like nothing. So you got to go 10, 10, 10, 10, 10 of Valium, or 50, 100, like a shit ton of Librium. And I've given like 500 milligrams over a period of time of Librium, and the guy's still wide awake, but he's not withdrawing. And so you can't be scared of that, but you have to have experience. You have to call for help when you're out of your depth on it. But you got to get comfortable with it, especially if you work in a county setting like UMC, that kind of thing. Because I see so many residents who underdo it, and then they're wondering why all the shit's hitting the fan.
It's basically like tranking a lion. You better have the right trank. Like,
Right.
You better have enough.
But the thing about the line is you don't worry about over tranquilizing them.
Right.
In humans, everybody's very stressed about overdoing it. So that's more or less, right? And you can get refractory delirium tremens, and that's when you're intubating people. You're putting them on phenobarbital, dexmedetomidine. You're putting them on propofol, those kind of things. Now, there are alternative ways to do this that the authors of the papers that I'm reading don't like. One is giving ethanol, which we talked about, just straight alcohol, not a good idea. The other are things like Haldol. So here's a patient having hallucinations who's jumping off the walls. A lot of times in the hospital for delirium that isn't alcohol, we give Haldol and Ativan in a combination. Well, it turns out haloperidol, Haldol, is not the best answer for someone who's in alcohol withdrawal. It affects heat metabolism, so people who are having hyperthermia, which is one way you can die from delirium, you can get a fever so high you can die. Because that's one of the things, you're disinhibited and the fever regulation is off. So Haldol, which is an
It's interesting because part of the delirium tremens sound a lot like when people freeze to death.
Yeah, except it's the
opposite,
It's
right?
temperature
But
dysregulation.
I can imagine, temperature dysregulation. The body's under an extreme stress.
That's what
Similar.
it is. It's really what it is.
Not the same, but similar.
You've taken the brakes off the body's autonomic system,
Yeah.
and everything goes haywire. And on top of that, you're not well to begin with because you're a chronic alcoholic.
Right.
So it puts you at risk in many, many ways.
Well, it sounds much more dysphoric to go through DTs than it does to freeze to death.
Yeah.
Hypothermia.
Yeah, well, the thing is, here's the thing. People who go through alcohol withdrawal, generally, if they hit the DT stage, they don't remember any of it afterwards. But at the time, they are suffering.
Yeah.
So it's like tremendous suffering, and then when they wake up at the end, they don't remember anything happened. Most people. So what do you think, Tom? Let's go to some comments.
Hit me with, what's a banana bag? Because people
Okay,
are
the
talking
banana
about
bag.
a banana bag.
There's my boy. Yo, Gabba Gabba banana. All right, so the banana bag, all right, is, and they call it a banana bag because it looks yellow. It's a bag of IV fluids that they put a multivitamin in, thiamine, a little bit of glucose, et cetera. And people will reflexively give that to alcoholics in the emergency department and on the floor because they know that alcoholics are vitamin deficient, thiamine deficient, folate deficient, and they need a little bit of glucose.
What seems like a steroided version of like, have a Gatorade and a burrito, dude.
It's it's a steroided version of the hangover heaven bus that
Right.
comes around Vegas,
Yeah.
right? And the problem is, the authors in this particular article say it doesn't do shit. So it's actually, it gives you a placebo feeling like I'm doing something, but really, you got to hit them with good fluids. You got to give them thiamine. You got to give them glucose. You got to give them nutrition. And if you don't do that, these are malnourished people already, and they're dehydrated. And fluid abnormalities are one thing that kill people in delirium tremens because they're vomiting, they're sweating, they're tachycardic, and they're not drinking or eating. So you have to take care of that as part of it.
Sarah wants to know, why is Haldol bad?
So Haldol is bad, and the authors here go into some detail on this. Treatment with antipsychotics would only be appropriate when a decompensated thought disorder like schizophrenia coexists with alcohol withdrawal, right? Because otherwise, routinely giving Haldol and other butyrophenones, including Haldol, they lower the seizure threshold, so you're more likely to have a seizure. Bad. And also, they interfere with heat dissipation and don't sort of have any cross-tolerance with ethanol. So they're not really helping the withdrawal directly. You're putting a Band-Aid on symptoms of hallucinations, but you're not treating the underlying cause, which is alcohol deficiency at this point. It's a GABA deficiency.
But it might be helpful in people with schizophrenia or possibly...
Right, so say you're schizophrenic and an alcoholic and in withdrawal, and you're having crazy auditory hallucinations that are your schizophrenia, then it might be acceptable.
What about PTSD? Because I can imagine a lot of the veteran community deals with that. Would that be on the same?
PTSD is different in the sense that if you're not having these psychotic symptoms,
Right.
auditory, visual hallucinations, hearing voices, those kind of things, you wouldn't have an indication to give Haldol.
Okay.
Yeah.
Gotcha.
Now, and again, I defer to a psychiatrist because there may be some indications.
And then what's Precedex? Precedex?
So Precedex
Precedex.
is hang on a second because I want to make sure that we speak about this correctly, because my anesthesiologist will get really pissed. And that's dexmedetomidine, which I talked about earlier. That Dex, as the anesthesiologists call it, is another kind of GABAergic sedative. And a lot of times they'll use it in anesthesia, in the ER setting, et cetera. And there was talk of using it in alcohol withdrawal settings, including by one of my mentors, Jose Maldonado, back at Stanford. The thing is, there's not a whole lot of evidence yet that it is, as a solo drug, a great choice. So it may be part of the armamentarium, and I mentioned it in passing when we were talking about phenobarbital, Dex, and propofol. So when you get anesthesia involved at this point, or critical care, they're just snowing the fuck out of the patient. Yeah. And so that's one option for that.
And then, hey, bro science, break it down for me. It seems to me people that do hard alcohol are much more likely to suffer severe alcohol withdrawal than people that just drink beer and wine. Am I just totally off base here? Or?
It's more that people who do hard alcohol have found that hard alcohol shows less on the breath. It's a quicker, easier way to get drunk, and they choose it because they're harder core alcoholics. But you can be just as bad with wine. I've seen the worst alcohol withdrawal I see is from beer.
Oh, really?
Yeah, beer.
Really?
So people who drink like a 12-pack a day on the regular, VA patients, and they get sick, they stop drinking, or they decide, I'm just not gonna drink anymore, bro. Next thing you know, they are literally, and it's the craziest shit, Tom, because they are insane when they're withdrawing.
Dude, I used to take the train out to the metro, out to the south suburbs of Chicago when I was living in the city in Chicago to visit my family. And I did it every day for about 2 weeks. Same construction worker got on every day with a 30-pack of PBR.
There you go.
Every day, and would drink 5 on the train on the way out to the south suburbs. And I gotta imagine he was killing the rest of the case at home every single day. It was crazy.
Wow. Name the movie. Heineken, fuck that shit. Pabst Blue Ribbon.
That's Blue Velvet, motherfucker.
You are good. You are good. Let's read some comments. My daughter just quit Friday, says Levon LaCroix Kroger. Wow, her middle name is LaCroix. I'm going to drink for that. No alcohol since, was drinking 5th quart a day. She seems not to have DTs. Seen doctor today, gave her meds that make her sick if she drinks. Right, so she's getting that route. Should I be concerned? Has it been long enough for her? So let's see, she quit on Friday, and what's today, Tom? Monday?
Yeah.
Friday, Saturday, Sunday, Monday. Yes, you can still be concerned. And this isn't medical advice, Levon. It's just friendly entertainment advice, which is
How many days would you be concerned for?
So typically, if you look at these paths, 72 to 96 hours is generally the outset for the start of delirium tremens.
Yeah.
Prior to that, you can get the other forms of alcohol withdrawal.
So after about 5 days, you're probably in the clear?
You're probably in the clear. Now remember, almost all delirium tremens show some sign of previous alcohol withdrawal before that. So if she's awake and alert, nothing wrong with her, no alcohol withdrawal, it's unlikely she's going to have DTs at day 4 or 3, but it's not impossible.
Right.
So constant vigilance, as Mad Eye Moody once said. Levon. LaCroix. Let's see. Yeah, see, other people are talking about Levon. Just use Librium, hang a banana bag, and call it a day, Anthony Garcia. So Anthony, if you do that, if you use Librium, long-acting benzodiazepine, hang a banana bag, give them fluid, and call it a day, as long as you're watching them and you're doing the CEWA protocol and you're asking the questions, you can probably get away with that. But if it looks like it's not working, you need to adjust really, really quickly. Let's read some more comments. And how is this related to hypothyroidism crisis? Laura Lynn, it generally isn't. Catherine Mansfield, great point. Plus with Haldol, you can get a long QT, electrolyte derangements like low mag combined with tachycardia, you're asking for arrhythmias. Haldol in alcohol is like using a super soaker to put out a forest fire, in my opinion. Catherine, that was fantastic. This is why I love the Z-Pak.
Would that be similar for Seroquel also?
So Seroquel is another antipsychotic.
Yeah,
but
you feel
it's
the same way?
Yes, but we often will give that at night for like people who are delirious and older.
Because it puts you to sleep.
It's Haldol is something you can give really fast and acute in the hospital, and you can give it IV, which is an advantage, right, when someone's not eating. Now, let me unpack something Catherine said. Long QT, what she's talking about is the QT interval on an EKG. And it's, for people who aren't savvy on this, it just suffices to say it's a way you can look at the electrical tracing and go, ooh, drugs or metabolic derangements or illness are causing a problem that can lead to a type of arrhythmia. especially when combined with low magnesium that Haldol can also cause, called torsades de pointe. And actually, Dr. Harry and I did a song called Doctors Today that you can look up on our website or on Facebook. And in that song, we were like, the patient's son down and da-da-da-da. I forget what the lyrics were, but it was like, gave Haldol to stop him from falling, check the monitor, it's torsade de pointe. So we even sang about that particular complication with Haldol. And in alcoholics, it's worse because their magnesium's all effed up. So I love that comment, Catherine. Let's read some more. Could you use Haldol for a quick PRN as needed, Ariel Schnell? Quick save just to wrangle the patient, Ariel Schnell. Well, this is the thing, Ariel. I wouldn't do that. What I would do is I would hit him with Valium or Librium or Ativan because that is treating the underlying cause and it is sedating them. You give them Haldol when they're in alcohol withdrawal and you can have all those problems. So it's not worth the risk. Whereas the other stuff is actually going to sedate them and treat the underlying conditions. That's why you want to go with that ideally.
Gloria wants to know, how often do you think alcoholics should really be assessed and the CWA scale idealized?
Idealized, maybe.
Idealized.
Probably autocorrect.
Should there be a set frequency?
So it depends. And a lot of times the authors of the article that I'm reading say, and I would tend to agree with this, as often as half an hour to an hour. And I know nurses hate to hear this because they got to go in and assess the patient and do this big questionnaire. But like once, if they're having fluctuating symptoms, you have to at least get a sense. Now, at least every hour, you can document a CWA score, tell the doctor, and if there's a protocol, you can give the Valium or the Ativan, right? And that's going to help a lot. Yes?
See, I got a question.
Yes, Tom.
Yo, Teach. Is it unethical to force a patient to withdraw from alcohol who came in for another complication and has no intention of withdrawing from alcohol?
What an interesting question. So Tom is asking, is it unethical? So they come in, they're an alcoholic.
They're an alcoholic, they
come
have
in with
something
pneumonia.
else that's wrong with yeah.
Come in with pneumonia, and they're like, I want alcohol. If I don't get alcohol, I withdraw.
Yeah. And you're like, time to go through withdrawals, motherfucker. You made some bad life decisions. Is that unethical?
Wow, so this comes up from time to time. This is how we handle it, all right? We tell the patient this. We can't give you alcohol in the hospital because we think it's unpredictably metabolized and it can interfere with your other treatment. What we can give you is benzodiazepine, so Valium, Ativan, Librium, to titrate to the level of your comfort. If you're awake and alert, we can give you more. And so it's kind of like our alcohol substitute. So we promise you we will do our best that you do not withdraw, but we're not going to give you beer, wine, spirits. So that's how we do it.
Listen up, bro. Alcohol, that's Little League, son. We got them good drugs here. You know what I'm saying?
That's what I, as soon as the team leaves, I'm like, okay, check it out, son. That shit that starts with a D, that's my shit right there.
Your boy got you.
Yeah, I got your back. Who got you? Blame it on the Demerol. Blame it on the Demerol. I don't know, Tom. Couple more comments? These comments
let's do
are great,
like two more.
Yeah. Let's see. Ooh, Tess Dunaway, problem. Providers being judgmental, including nurses, instead of an objective assessment is a huge problem. Believing patients and those withdrawing or lying and drug seeking, even when the CWA and COWS protocol, which are subjective, are available. Yep, Tess, listen, if 40% of the patients in the hospital have some alcohol use disorder, you better just take it seriously, right? Interesting, in the 70s, we had to just tie down people in delirium tremens. They didn't use tranquilizers, Deb Higgins. That may explain the 37% mortality rate, don't you think?
Christy Columbus says, God, Zubin's a good doctor. Totes real hard tonight. This is why Zubin burned out a lot quicker than other doctors. Because he actually cares.
Oh, I don't know if I'm laughing or I'm crying, Tom Heiner.
Takes most doctors 30 years to burn out. Zubin did it in just 10.
I'm a gunner, son. I'm like, you want to burn out? I can burn out faster than any other motherfucker on the planet. No, but all joking aside, let us know, guys, if you think this form of teaching, which is fairly casual, lots of F-bombs, and actually, I really enjoy Tom and Logan's bro-terruptions because they allow us to talk also to, yes, activated GABA muggles, LaCroix bitches. So if you like this format, let me know and we'll keep doing it. hit me with topics you want to talk about. See, the things I really am passionate about are often hospital related because that's my specialty in training. But if there's other shit, I'm happy to learn and talk about it. What I like to be able to do is give you my own sort of spin on it because, a decade in the hospital doing that stuff, you learn a thing or two. And you also learn some interesting stuff, which is the way we practice medicine is a lot of seat of your pants. It's a lot of intuition and a bunch of old guys sitting around a table saying shit like, don't give alcohol for alcohol withdrawal, or actually give alcohol for alcohol withdrawal. It'll change all the time. And I think having the conversation and getting people's input and sort of crowdsourcing input is a good idea. So that's my thought.
Heck yeah.
What you think, Tom Heineber? Any other good comments? Gabba, 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 gabba.
Daniel Heineber says, I love this education. Well, that's because you're smart and pretty, girl.
I think that's the first time your wife has ever complimented the show. But like my wife, they're both like, this show sucks. Because that's what my wife said.
So true.
Yeah,
so
which
true.
is great. That's what keeps us pushing to try to make it better, guys. Oh, if you do love the show, we really appreciate it if you go to patreon.com/ZDoggMD and donate even $1 a week. Every week you get a summary of all the shows. If you sign up for our email list on our website, ZDoggMD.com, every week we send an update of everything we've done that week. So you can pick and choose what you want to watch. And if you donate enough, Doc Vader will make you a customized video. So if you have an organization or group that wants a Vader thing for their Christmas party, donate on Patreon and Vader will come correct. Correct, son, because we will shill that Vader.
That's right.
What you think?
And listen up, people. When you booze, you lose.
I miss Shamu. Remember Shamu?
Dare to keep
Liberals
Tom
shut
Heineber
down
off.
Shamu, man.
Goddamn liberals.
Goddamn liberal.
Trying to keep big fish in the cage, Z. America.
America.
Trying to keep them right in that cage.
Yep.
I hate you so much, Tom Heineber. And we out.
Go, go.
Freedom!
Freedom is free.
That's the birthday.
America.
That's